Hello, everybody. Good afternoon, or maybe good evening from where you are. My name is Geert MEYFROIDT. I'm an intensivist from Belgium, and I'm the current chair of the Neuro Intensive Care section of the European Society of Intensive Care Medicine. It's a pleasure and an honor to be able to host this session together with Julie BENBENISTHY. We have, from the comfort of where I am at least, it's very hard to judge the difficult challenges you are in, and we are trying to reach out to you and help you as much as possible. And for this, group of sessions have been organized. So today we will discuss penetrating and crush injuries. The idea of the session is, and it has been confirmed to me a couple of minutes ago, that there's no formal talk. So the session actually depends entirely on you, on the questions you ask and the discussions we will have. Please don't be shy. That's absolutely not the idea. None of us considers himself better than any of you, and maybe the experience that you have we can learn from that as well. So please don't be shy. Use the chat or open the microphone to discuss. And I'm sure that we will have an interesting hour in what follows. And Julie will introduce the speaker, of course. Sorry.
Yeah. Thank you, Geert. My name is Julie, and I'm an ICU nurse from Jerusalem, Israel, and I have been the trauma coordinator of my hospital for the past 12 years. I'd like to introduce my distinguished colleague, Professor Sharon, EINAV, who is an intensivist in a high volume trauma center, also in Jerusalem, Israel, but another hospital than what I'm working with. Both of us have had extensive experience in working with crush injuries and penetrating injuries. Professor Sharon will introduce herself and her clinical background. Thank you. And I'd like to especially thank Professor Sharon for EINAV for joining us today, because this was very short notice and she recruited herself to join us. Thank you very much. Sharon?
Thanks, Julie. Yeah, well, we go a long way back. It just happens that way. I didn't even realize that she was going to be the coordinator of this session. Like Julie mentioned, I have worked both inside and outside the hospital and on trauma. 10 years on the Israel EMS ambulances in Jerusalem during one of the worst periods of our experience with blast injuries, but not only. And in hospital, I'm an intensivist, so I work in the ICU and sometimes in the ED as required. So I just think that it would be great if people started to ask relevant questions. I've prepared no slides. I was given the understanding, like Geert said, that this would be an open session, and I think that the best thing would be just to start, with the first couple of questions. And if there are none, I have to say what I have prepared are a couple of x-rays that could be provocative and lead the conversation.
We can actually start by asking the audience a question, and we can survey the audience, because Sharon and I had discussed before how we would go about talking about this subject, and it has a lot, and how we would approach this subject has a lot to do with what kind of facilities and resources you all have that are listening to us. So we're all going to ask you, so I'm going to ask you a question now, and please respond by using the chat, okay? There's going to be two questions. The first question is computer-assisted robotic surgery available in your medical center? Just yes or no in the chat. And your answers will kind of navigate how we will be able to help you in our answers during this session. Is computer-assisted robotic surgery available in your medical center? This is especially relevant when we're talking about shrapnel and penetrating injuries and how we would go about treating those injuries. And that's why this question would be relevant in how we would discuss treatment of penetrating injuries.
Apparently, no one reacts, Julie.
Yeah, I haven't seen anything.
No. So maybe we can start explaining why do you think this is so important?
Yes, 45 people have said that they do have computer-assisted robotics, and 57 have said no.
Okay, very good. Yeah, it's a pity that we can't see, or maybe it's another way, but we can't see the answers apparently. So apparently this goes in another chat.
I'm getting the answers through the WhatsApp.
Okay, great.
Okay, so it's about half and half, Sharon, that do have computer-assisted robotics, and 50 and half don't. So, okay. Oh, they're in the polling system. Okay. That's the percent. So it's 50-50%. The second question we're going to ask you is negative pressure wound therapy available in your medical center? Negative pressure wound therapy. In my hospital, we call it VAC therapy. What do you call it in Sharon? Do you call it negative pressure?
VAC.
VAC, you also call it VAC?
Yeah, we call it VAC as well. Yeah, I think everybody calls it VAC.
Yeah. So the question is, in order to, one of the ways that we treat crush injuries is using VAC system. So is this available, the VAC system or negative pressure wound dressing, available in your medical center? And we're going to hear the answers. Okay, so we're going to wait 2 or 3 minutes. How I don't remember when we started VAC, but it's not a very many long years. How do you remember when we started it? Do you remember, Sharon, when you started it?
Yeah, I think that the first case we saw was actually interestingly enough, it was a case of mediastinitis. So, but that was a good while ago.
Yeah, I think here as well as the first facts that I saw were after cardiac surgery for mediastinitis or sternitis.
Really?
And then they sort of sneaked in other indications, not always as good. But I think now they are somehow in the correct position as we use them. Unfortunately, still not with a lot of big trials, but that's how it goes. I think, especially when surgeons are convinced of something, they're not inclined to retest that hypothesis or randomize patients, which would still be interesting, I think, even for the sternitis that we had in the beginning.
I know as a nurse, I'm very happy with the results of the new generation of when you have so much tissue missing from a person's body, from a crush injury or a burn injury, and there's so much tissue that's missing. This type of wound dressing, this is good. This type of wound dressing generates new tissue where we didn't have a solution for this problem.
Yeah.
In our poll, 72% of our participants do have this type of therapy available in their medical center. Okay, so this is a good place for us to start. I don't see any questions, so
I have a question for you, Julie. When you start with asking the question to robotic surgery, I was myself wondering, well, this is already advanced. I mean, is this the first question you have? So can you maybe explain already, or Sharon, or both of you, what the importance is and why why it's maybe worth investing in this technology, in particular with regards to these injuries?
So I think that the answer lies in the telling. We used to, many years ago, when there was shrapnel, we used to chase after it. And basically, you saw a piece of shrapnel, you knew you had to take it out. And there was always a question, what shrapnel to leave in and what to take out. And as technology improves, we can be more exact on those areas or digging in those areas that can be problematic. So for specific areas in the body, like brain, obviously, some orthopedic injuries, spine, robotic surgery can be very useful for locating shrapnel and pulling them out with causing minimal damage. I think that would be the reason that Julie asked this question, because nowadays you'll be taking out only those pieces that are really in line of your surgery, and only then looking at the rest and asking yourself, should I even bother digging there? And usually the answer will be no, unless there's concerns about things moving from one place to the other.
Yeah. And in particular, for instance, I can imagine for intrathoracic shrapnel that it's quite interesting to have a robot there, where for other areas you might want to go for a more traditional approach.
It depends really, because it, if there is anatomical disruption of a crucial, if there's a disruption of crucial anatomical structures, then obviously you must pull it out. But as we know, and we've seen, even in war injuries in the chest, people can live with shrapnel that sits there and has not been taken out for many, many years. So it really depends. Obviously, if it's sitting on the pericard and you want to take it out for some reason, then that's completely different. But yeah, the question is how to access with minimal damage.
Yeah, so for some of these pieces of shrapnel, you would even propose then a sort of follow-up program where you regularly try to follow up on the evolution and where the shrapnel is and does it move or not?
Absolutely.
Yeah.
Yeah. Most certainly in a situation where you have like a war situation, or when you have multiple injured patients coming in, and pulling out every single piece would not be a priority. And then you decide what injuries must be prioritized, and life-threatening or limb-threatening shrapnel you will take out and deal with, but other things you will leave in place and then send for further follow-up or further surgery or more exacting surgery later on.
No. We already have a first question from the chat, and it's taking us back to the early pre-hospital phase. And somebody asked on the use of tranexamic acids in war injury specific. So how do you use it pre-hospital or in theaters of war? I suppose they refer to the scene, the out of hospital scene, and not to the operating theater. And how do you manage it? Which patient, I suppose, is the question more specifically?
So I can say that in, for example, our military has now had addition of both blood and, if you wish, corrective therapy added to the protocol of the pre-hospital treatment. It's, I'll put it this way, it's controversial. I know some trauma surgeons are very much opposed to it. I also think that when you're looking at pre-hospital treatment, both in terms of blood components and medical treatment for massive hemorrhage, the most important consideration needs to be the amount of time that it takes to get to damage control surgery and stop the bleeding. So we know that hemorrhage is a crucial, is probably reason number one for pre-hospital death. And definitely in a military scenario. And and the question is how to control hemorrhage. Ideally, it would be with you know, some form of local modality to put pressure on the wound rather than give medications and walk away. However, sometimes there aren't enough people, and you do need to find solutions. Tranexamic acid is probably not the ideal solution for this situation. If you have somebody to give tranexamic acid, it's better to have them press on the place of hemorrhage.
Yeah, but the one doesn't necessarily exclude the other, of course. I suppose you can get hemostasis, because if you can't get hemostasis at the scene, I suppose there's a high probability you lose the patient anyway. But suppose you can get hemostasis through a tourniquet or what, so you get good hemostasis for transport. Would you then give the tranexamic acid already out of hospital? Or do you, it probably also depends on the transport times that you can
Exactly.
get, I suppose. Yeah.
I think you just gave the answer. If the transport time is prolonged and you find yourself with massive transfusion, I think that could be something that you would enable consideration or give to the teams. But if you know that most patients will be transported within 20 minutes or half hour at most, or within the golden hour, which is what we would like, then I think that can definitely wait for the second round or the third round of blood. Again, life-threatening injuries in the pre-hospital, if they're not brought into hospital within minutes, it doesn't really matter much what we give them. And there's very little literature that you can actually transpose from one scenario to another. So if you're looking at Iran, Iraq, or Afghanistan literature, and you're trying to take that into your own scenario, you have to know what the transport times are, know what the abilities of the people are, and what the facilities can give on location.
Yeah. So I can imagine that there's sort of, rather than the traditional approach of being out of hospital and then to a trauma center, there's the intermediate step of the field hospital as well, I suppose, where already some things can or should be done before transport. And so maybe in your blood and coagulation management, this also might play a role in the equipment that you have in each of these different steps.
So there is what's called a forward hospital in this scenario in many places where initial damage control surgery is performed, and in that scenario, in that place, then absolutely tranexamic acid would have a role, for example, as would blood components and blood. And the transport time to that forward hospital, again, usually it's something that is very makeshift. It's in the area near, more near, let's put it that way, the front, and that way, and then you have to take into consideration the transport time from that area later on. But again, if you're talking about an urban scenario, then I think you have to rethink the concept, because within an urban scenario, transport times, even in war, and we know there's urban war, are shorter to the nearest facility, and therefore there may not just be any justification for a forward hospital, if you wish. So it really depends what's available around you. I think that the crucial question in this scenario, in any type of injury, whether it be crush or penetrating, is what is called situation awareness. And if you know, when you are there treating a patient, you need to know what's around you in terms of how many people you have, how many hands you have, where's the nearest place you can bring your patient, where's the nearest place the patient can receive definitive treatment, what the transport times are, and so on. I think situational awareness is number one. And that's the major problem with the war scenario, that things are dynamic. And if you don't always have information at hand, a lot of it is guesswork, and you're trying to figure out what's the best way to handle this patient and not lose them on the way.
Yeah, okay. I think that's already a very good advice, and I think your sketch of the urban scene versus the sort of battlefield or out of or non-urban scene is indeed something that is quite valuable. So just for the audience, just to make sure, I have no experience at all, luckily, with war. So I'm going to be the one to ask all the stupid questions. So which is good, I suppose. So no, my only experience, unfortunately, were the Brussels attacks, but that's a semi-urban scene where patients were first triaged in the military hospital and then dispersed immediately to the good hospitals that we have in Belgium that were not under attack at that moment. So we discussed a bit about transfusion management and coagulation management. Is there anything else in this pre-hospital scene that you want to, and then of course the importance of at least temporarily stopping the bleeding? Is there any other specificity to war trauma that is different from other trauma that you want to give to the audience here, Sharon, in this let's say pre-hospital or field hospital scene?
So I think that the important aspects are transport times, which I've talked about, that they can be quite prolonged in this scenario, and the thing that should be taken into consideration here is temperature, maintaining patient temperature. We're talking about Europe, and it depends on the time of year, but obviously it can be quite cold outside if a patient lies outside, and a situation where mild bleeding becomes DIC can be easily envisioned if the patient's temperature is not maintained as if possible. So that can exacerbate it. I think in the pre-hospital, those are crucial things. I think that the previous webinar was actually on hemorrhage control. So I think that even, talking more about that, could be interesting if people have questions from the previous one, but there are additional aspects that I think we need to address in relation to these specific injuries, maybe.
Okay, do we see any questions from the chat now?
No, I don't have any, but I do have some pictures of clinical photographs of the crush injury patients. So I think if we brought maybe those pictures up and we would discuss how we would manage that kind of injury. Can I share my screen? Yeah. Oh dear, I don't see this. I don't see them here. Okay, I don't see.
So while you're getting this organized, let me just try to, the way that you look at a patient, I think sometimes the concept of a trauma patient is, to make it very simplistic, is looking at compartments. And I think that if we're thinking of various compartments in the body, we were talking about hemorrhage, and now we will be talking about probably some sort of compartment syndrome, which Julie will discuss with Crush, I suspect. So I think talking about hemorrhage, there's several compartments where patients can bleed into the chest. Each hemithorax would be one compartment, which could easily have several liters in it. There would be the pelvis and the abdomen, which would be intraperitoneal hemorrhage. That's another area. Retroperitoneal hemorrhage, which could extend into the pleura. You could have several liters in there as well. Two femurs, those are compartments that we need to discuss. And if we look at the patient that way in terms of compartment, when we're scanning them for bleeding, that's very useful, because then you say, okay, so femur 1, femur 2, abdomen, ultrasound, retroperitoneum, I'm going to see their pelvic fractures or no. Thorax, I can see an x-ray. So you sort of rule out those major compartments and you're done with that question initially. And you can do that in the field many times, or at least some of it.
If you say screening, Sharon, or scanning, and you already mentioned ultrasound, do you see a role for ultrasound pre-hospital or in this, let's say, field hospitals already?
Absolutely, and
yeah.
on ambulances as well, paramedics, Even, you know, EMTs. I think that, you know, we know that the ultrasound is the new stethoscope, and the expectation should be that every new generation in medical school finishes and has basic ultrasound abilities that should allow that sort of initial screening, like rough things.
No.
Yes, absolutely.
No. Julie, so maybe before we move to your picture, there's a question in the chat about the recommended equipment and monitoring as a minimum. I suppose we're still talking about the pre-hospital or the field hospital phase.
So, you know, I can only tell you things that from our experience are like, if you really look at minimal pre-hospital for transport, then I would say if you have nothing, then you use nothing.
Yeah.
But if you do have, or you could select things to use, I think that a pulse oximeter will give you both saturation and perfusion. End-tidal CO2 gives you, if you're intubating a patient, gives you pulmonary perfusion, blood pressure. It gives you an indication of things that are happening hemodynamically as well as ventilation-wise. So that could be useful. Although when the two things happen together, it's very confusing. So that's another thought. And a capnograph, you could, you know, these are all things, you have these small things on your finger that you could use for saturation, for pulse oximetry, and you have very small capnographs like with microstream technologies and so on that you could use. And I'd say, you know, if that's what you have, go with it. That would be minimum.
Yeah. Okay, very good. Julie.
There's another question. Do you think REBOA has advantages in the pre-clinical setting?
I think that I think that, again, looking at the literature, it's almost like the literature is divided to pro-REBOA and not pro-REBOA. I won't say against, but not pro-REBOA. I think that any treatment you're giving to the patient, you need to take into consideration, again, the location, the expertise, the transport time, and what's your endpoint. And if you have one patient that's going to consume all of your resources, you need to think well whether you're going to use the most extreme resources in a war scenario for that patient. I would rather save 5 patients with the same resource. I think that needs to be always in the back of your mind. So again, you know, REBOA is fine, but think about what it entails at every step of the way.
Yeah. Actually, I have the feeling a lot that we're discussing is the ancient scoop and run versus stay and play discussion, where play, I think, is a very unrespectful term of what we're doing, but you know what I mean?
Yes.
And as you say in your answers, it depends on the situation, the resource, and the transport time, and so probably transport time will be your answer to any of these questions, I suppose.
Yeah, we're talking about pre-hospital scenario. For pre-hospital scenario, yes.
Yeah.
So Julie, this is a picture that you...
Yep, this is a 19-year-old girl who was crushed between 2 buses. And as you see, there was extensive damage done to both her legs, including her feet, and to her pelvis. And when she arrived at our medical center in shock, and we immediately took her to the angio suite, and we were able to stop the bleeding in the pelvis. And of course, she was with a crush injury, a lateral compression of the pelvis itself, and she had to have an external fixator. So the external fixator, with extreme damage to the tissues in the lower part of her body, she was in a critical state for quite a long time. But these pictures already, you can see, are after some skin transplants. Is this what we say?
Grafts.
Skin grafts, thank you. We use skin grafts as well as the VAC with her, and all this was all infected. You see, there's yellow. It's like with pseudomonas here. And
So,
she had, yeah.
So I'm glad you brought this case, Julie, because you know, I think that it raises a lot of questions. First question, I think the first thing I think is important to know, just looking at that, you know, off the top of my head, is what types of injury, what types of crush injury are more likely to end up requiring fasciotomy. I think that's the first question. You know, what we're seeing here is our late photos, but you know, you receive a patient and they have extensive injuries. What requires fasciotomy? So I think that it's interesting. This case you brought has several risk factors. One of them is the extent of soft tissue injury, and as the extent of soft tissue injury increases, so does the likelihood of fasciotomy. Just looking at crush injury in general with rhabdomyolysis, not every single case will need to undergo fasciotomy, but when the tibial areas, fibula areas are involved, then there is more need for fasciotomy, because it's an area that doesn't have a lot of place to expand, and therefore the crush often exacerbates the situation. And the second thing is age, because muscle mass is higher in younger patients, so the likelihood of rise in the CPK, myoglobin, and so on is higher in these patients with extensive crush. Another thing is open versus closed damage. So crush injuries with open fractures are more likely to require debridement and fasciotomy than those with closed injuries. So it really depends, like I said, on the extent of tissue damage. In this case, I imagine that medial, looking at that lead, that medial area is probably part of it is either grafts taken or some sort of decompression.
Yeah.
That area, because that would be one of the 3 compartments that require opening.
Right. Yeah. Yeah. So what do you say about managing? You talked about CPK monitoring, and so how often should we take CPK? How do we manage the amount of muscle loss? How do we control it or monitor it, or what? What should we do with the CPK?
So let's just first talk about what we need to, and you're talking about rhabdomyolysis now. We're talking about crush with rhabdomyolysis.
Right.
Okay, so in order to define rhabdomyolysis, basically, I think the most commonly used definition is 5 times the normal level of CPK would start being, you know, some form of definition. Unfortunately, not every single study has used the same definition, but those that are, you know, trying to reach some sort of consensus do talk about 5 times the normal level of CK. Initial CPK and myoglobin levels do not necessarily correlate with later levels. The CK levels increase during the first 6 to 12 hours, then sort of stay stable days, I don't know, probably 2, 3, depending, again, it depends on the mechanism, and if there's ongoing damage. For example, if it continues to rise beyond 12 hours, I would start looking actively for areas under pressure, areas to decompress. So when you see a constant increase beyond 12 hours, that should raise concern. And then afterwards, assuming that you have decompressed everything, then levels should remain stable until approximately day 3 to 5, and then decrease going on from day 6 onwards. That's in terms of CPK. Myoglobin can be measured both in the blood and in the urine. Some hospitals have decided not to measure it anymore because you can basically use CPK as a marker. There's no studies actually showing consistent definitions of above this level you're going to get acute kidney injury. Part of it may be because of the different types of injury that the patients have had. Some of it may be secondary to the different types of treatment that the patients are receiving. But you cannot say, oh, there's 12,000 CK, so that means that there's going to be AKI. Nobody knows. There's one study that did look at myoglobin levels, and by the way, myoglobin levels are only detectable above a certain level in the urine. They may be there, but non-detectable. It really depends on the test that you're using. So it's always useful to ask the lab what exactly they have for the urine. And please don't confuse the fact that a urinalysis is positive, because it could be positive for myoglobin and blood, which both release heme, and therefore there may be overlap. So that could be tricky. So you have to then do a slide if you cannot check myoglobin or CK to look whether there are actual RBCs in the urine, to ensure that what you're actually seeing in the urine is myoglobin if you've just done a dipstick. Mm-hmm. So that's tricky to know. So that's, I think, related to myoglobin and CK. And again, even the definitions of AKI in the studies looking at rhabdomyolysis are inconsistent. So, not everybody uses rifle criteria, not everybody, and therefore to correlate them with the levels is tricky. And I would just follow up once every, during the first hours, definitely, at least the first 6 hours, going like every 2 hours, and then even more, because if potassium levels begin to rise, and then only when you see stabilization of potassium, phosphor levels, then you can afford to start, decreasing your level of monitoring. You're not expected to see a rise of potassium within less than, 20 minutes, half an hour, or so on. So, if you've got that transport time, you don't have to have an ECG pre-hospital. You don't have to have, an electrocardiography, full electrocardiograph. Just bring the patient into hospital, and that'll be done later.
Thank you.
So how would you control your treatment level and according to the CPK level? I mean, other than fluid.
So I wouldn't. I actually, so basically what you would do is, so let me just say what off the bat, that everything I'm saying is, there's absolutely no RCTs on rhabdomyolysis. Okay, there's nobody actually randomized trauma patients to with 200 cc's of fluid or with 400 cc's of fluid per hour, or fluids with bicarb or versus fluids without bicarb, or normal saline versus Ringer's lactate. There's absolutely nothing, like literally nothing out there. The largest studies that you're going to find comparing one group to the other are something like 25 patients. And even those meta-analyses, or if you want systematic reviews, because it's not really meta-analyses, even the systematic reviews that have been performed put an emphasis on the fact that it's not RCTs, it's observational data. So what I'm telling you here is really sort of an amalgamation of the literature that exists, but very, very evidence poor, if you wish. In terms of monitoring, I would say that, so the patient comes in, you take initial blood tests. if you're taking the patient directly to the ICU and they're not bleeding at the moment, and you know you've got crush injury, I would say that upon arrival at the ICU, which hopefully should be within an hour or two, take repeat tests, do an ECG, perform an ECG. If potassium started to rise, you've got to be on it. You've got to take blood tests like every hour or every hour and a bit, because from the point that it starts to rise, it can be really fast.
Yeah.
And if your patient's not passing urine, then your goal in life is to make that patient pass urine. I think that's an important point to highlight. And there are several ways to do that. First and foremost, fluids. Personally, and again, I'm saying this is a personal choice, I like fluids with less chloride because of the sepsis trials showing more renal failure with chloride. Because of the studies on pancreatitis showing more renal failure with chloride, but there's zero proof on any other model. But this is just my personal preference. If you ask a nephrologist, they'll probably tell you, give saline. Or give a balanced balanced solution.
Do you use bicarbonate to alkalinize your urine, or not on purpose?
So we used to, and I have to say that the literature, you know what, I don't know if I have here. We had a systematic review on rhabdomyolysis several years ago, which was published in the Journal of Jean-Louis Vincent, and we actually looked at what papers described they gave, and everybody gives a different mixture. Some give without bicarb and some with. There's no comparison. There's a single comparison showing with and without bicarbonate in 6 patients, showing no difference in AKI, but hey, it's 26 patients. We used to give, and I have to say that many times you find yourself giving bicarbonate for massive transfusion in parallel. So, and you might end up having both volume overload and hypernatremia at a later stage where it becomes very tricky when you want to, the patient starts to have ARDS and so on. So I tend to give fluids without bicarbonate, definitely for the first few hours, see whether the patient's passing urine. Definitely if the pH in the blood is higher than 7.2. There's also a whole argument about the value of intravenous bicarbonate for patients with acidosis in terms of what happens intracellularly, because it exacerbates intracellular acidosis. So that's another issue. So we tend to start definitely without bicarbonate, and only if we feel there's a need to correct renal failure with bicarbonate, then we would give.
Okay, good. There's maybe before Julie moves to the next slide or picture, the questions on pre-hospital coagulation management keep on coming in. So there's one about the use of freeze-dried plasma, and then the other one, which is maybe interesting when we discuss transport time, the other one actually asks for a cutoff in transport times with regards to blood products pre-hospital. I don't know if you can comment on that, Sharon. I think it's a very difficult question, but maybe you have some answer there.
So there's everybody knows there's the golden hour, and then there's the platinum, I think it is called half hour. So I mean, those are like the surgical slangs, if you wish, for ideal transport times. Half hour is a lot for a patient that really has lethal hemorrhage. If Julie will allow me, I can share a picture of a patient that we received this week. Let me see if I can share my screen. I don't know if I can share my screen here. Yeah, I can. So there's this case here, just a sec. Let me see if I can, I don't know if you're seeing this.
Yeah, we can see it.
Yeah.
Okay, great. So let me just go to the right slide. This is penetrating. So this is a patient that we received this week. Here's the SIR view down here. Let me maybe do it this way. Yeah, there you go. So the SIR view is down here. And then you can see the here the chest. I'm starting with the chest, the scan of the chest. You can see here the chest drain, air in the mediastinum. This was a person that got shot several bullets. So you can see here the air in the mediastinum, but so we performed an echo. But what I wanted to show you, and let me just go down, scroll down, is this. This patient had 2 potentially lethal injuries. What you're seeing here is the remnants of the liver after initial damage control surgery. So we didn't do a CT. The patient came in with shock and was taken immediately to the OR. The patient, you can see here, 1 piece of shrapnel that was actually never taken out later on. And here you can see packing. So the surgeon basically packed the abdomen, stabilized the patient, we transferred him to the CAT scan. After that, once he was stable enough, and these are the first x-rays that you can see. So this sort of injury can kill a patient within, the reason that I'm showing this is this sort of injury can kill a patient within less than 10 minutes. So even the platinum half hour would not be enough. This patient was extremely lucky. He had the injury occurred pretty close to our hospital and he also had a second lethal injury, which you can see also on the survey, but I'm going to show this here, which is this. This is a dual energy CT CAT scan showing actual hemorrhage, which you can see here, these trails of blood down here from the femoral artery. So these are 2 lethal injuries in 1 patient. He had a tourniquet on 1 leg and the packing was performed on the other. The tourniquet was done pre-hospital. But if you see a patient with this type of penetrating injury, if they're not in the hospital within, you know, that 15 minutes, those 15 minutes, they'll probably not survive despite the tourniquet because of the abdomen. So when you have multiple shrapnel or multiple gunshot wounds, again, those compartments, they're working. This is both femur and, in this case, femoral artery and liver. So the time, again, depends on the type of injury. And I'm glad I just prepared this by chance. We were talking, Julie and I said, you know what, we had this case this week. Why don't I just prepare these slides? Because just in case somebody asks about, you know, what type of injuries and if people want to discuss this. So, so these are both potentially lethal injuries. The leg could be survivable with more than a half hour pre-hospital, but this no.
Yeah.
And the other question here was?
It was on dried freeze plasma.
Well, yeah. So again, the question, probably if you have a scenario where waiting times are more than 6 hours and the patient slowly oozing out and getting cold, you could justify that. I think. I hope you guys agree with me. Again, this is more sort of, you know, all these surgical things, like you mentioned, surgeons sort of tend to just, oh, we can do this. And then the proof is in many times not there. It's sort of like a penicillin thing. No.
Yeah, this patient is indeed, it's a good example of, I mean, suppose with this patient, you would be in a setting where you can transport quickly to a field hospital, then it's only packing, and then you would need your blood products there, right?
Yeah, you would pack.
Yeah.
So what I can show you, I think I also prepared, I don't know, let me just see if I have the list. Here you go. Okay, you can actually see this is the same patient. On that same day, the first surgery that was done, it was 1 a.m., was this. And as you can see, this is basically damage control surgery.
Yeah.
Even in the hospital, what was done was damage control surgery. And so because that enabled us to perform the CAT scans, to correct the blood abnormalities, you know, the coagulation abnormalities, to warm the patient. And then after the CAT scan, patient was taken to second surgery where instead of just sticking a piece of, you know, like tube in the femoral artery, they actually did a vascular correction because there was no other choice. You couldn't just leave the patient with that. But the liver was done the next day.
Yeah. I think this is a very interesting example, Sharon, especially for the people who have this question about pre-hospital and times, because you can so clearly see the times of what you guys did in this patient, where you it's actually quite clear how far you go up to in the first phase, and then you have some time maybe to transport or restabilize if necessary, and even you can do a second transport as well for your third level surgery somehow.
Yeah. So I chose this because I think it's great damage control surgery. I think that the clinical judgment here was great. The debridement here, for example, that you can see here was only to decide whether to amputate that limb immediately or not. And as you can see, the amputation actually took place 3 days later. So, or 2.5 days later. So there are things that are urgent and things that are not. And I think that if you can stop the hemorrhage and then stabilize and think and plan, the surgeons, you know, sometimes you need to wrap your mind around the type of injury that the patient has. It's, you know, this is the amazing thing about trauma. It's almost like a, you know, I don't want to say this in a positive way, but it's like getting a present. You unwrap it, you never know what you're going to get.
Yeah.
And that liver was like, oh my God, you know, they opened the abdomen and poof, it was up there. They couldn't even perform a Pringle maneuver to occlude the liver because it was so, everything was, you know, everything was full of blood. So what they did was they just packed and went to CAT scan. So I think that that's a great example.
Yeah, yeah, absolutely. Julie, since we don't have any questions, maybe you want to continue with your second case? Unless I'm missing questions, of course, because we have some.
I don't see any questions either.
Yeah.
I think we can continue with the crush a little bit.
Or
Because,
continue with the crush as well. Do we have some crush and some penetrating already?
yeah, that's some crush, some penetrating. So Julie, so I think, you know, we mentioned the CK and myoglobin, we mentioned the potassium, which requires obviously ECG monitoring later on and following up on electrocardiography. I'd like to mention two things related to the potassium and phosphor. That we tend to give calcium in order to stabilize the myocard when we have hyperkalemia. In crush injury, giving calcium could actually exacerbate the release of toxins from the muscle. So, and I think that's if there's absolutely no choice, and the patient has severe electrolyte, you know, severe electrocardiographic abnormalities, and the patient's, you know, widening of QRS, a very impressive U wave or something like that, then you might think of giving the calcium. But otherwise, I would do everything to try and avoid giving calcium and managing the potassium by giving fluids, giving, you know, diuretics, doing anything else but that, insulin, glucose, and so on. So I thought, you know, just that little thing with the calcium merits mention.
Yeah.
Julie, the second case you were presenting, was it also a crash trauma or?
Sharon, you need to stop share so I can share.
Done.
Okay. I just want to say one thing, because I'm the trauma coordinator, I have long-term, I follow up my patients long-term, and this woman is 9 years after this crush injury, and she has many residual injuries that are not going to ever get better. And the worst of them is the neuropathy that she has on her feet, because she has drop foot. So she falls a lot, and she can walk and have blisters and bleeding feet, and she doesn't feel anything. So, and her ability to become pregnant is severely compromised. So these are the long-term residue of a crush injury. So
yeah, is there anything you could have done to prevent these long-term consequences when?
I don't think there's anything we can do with the neuropathy, with the nerve damage that was done from the hypoxia of the crush injury. And but she's she's done her master's degree, and she works now in the Ministry of Health, and she has a very high-powered job, and of course she's functioning. But when we have our debates, if I think she's a success after trauma and she thinks she's a success after trauma, there's a big difference in our conception of what a successful recovery after trauma.
Yeah.
Julie, so perhaps this is a time just to mention, with regards to what you talked about with the drop foot, that well, nerve injury obviously is nerve injury, and that, I'm not going to go into that, but I do think it's important to mention the need to involve physiotherapy early in order to prevent contractures and have, to make sure that the feet are positioned well within, how do you call those? The nurses always put them on.
They're absolutely splints. They're actually
splints. Exactly, splints.
Padded splints that we use in order to prevent drop foot. And drop foot can happen to any patient that's in ICU, regardless of if it's injury or pneumonia. So we have to really always be careful and maintain that we don't cause secondary injury just because of the hospitalization and the neuromuscular weakness.
So how soon would you call physiotherapy, Julie? You're a nurse. Nurses sometimes do that.
As soon as possible, especially with such an immense tissue damage to this patient, we called them right away. And working with her, as soon as she was awake, we worked with her doing exercises, and she would push against my hands as much as when I was sitting and talking to her, she would push against my hands. So that's, you don't need a physical therapist. There's a lot of other things you can do to keep it, to maintain as much as you can of the muscular functioning. So this young man, this is a very recent picture of almost within a number of hours that he arrived with us in a crush injury. So we see that, of course, we took the pulse oximeter of the wounded extremity to know if there was any oxygen in this or tissue perfusion in this area. And this is what he looked like. And why did I bring this picture? This is also something that we talked about. His family read something about using the hyperbaric chamber in order to give oxygen to this area, to provide a lot of high concentrated oxygen to this area. So before I tell you what we did, what do we know about using a hyperbaric chamber? I know there's a lot of research now being done for other illnesses, but what have you read about it?
So for crush, I have to say that I have not gone into the literature on hyperbaric chamber, but I do know that, like for diabetic feet and for areas with low perfusion, that would definitely work. So if there is it does make sense to think of that option. I would definitely look that up and see now that you've raised it, because that's not something that we have used. And they're small chambers, by the way, that you don't have to actually fit the whole patient in. So it could be quite easy to do that if it actually helps. So what's your experience?
In this case, because the family was so demanding of it, and other than this foot, he was a stable patient. So we said, okay, we have nothing to lose by trying what the family wanted. So we did try it. We did send him to a local hospital that does have ICU facilities inside the hyperbaric trauma chamber. He went there for 2 or 3 days, and then he came back, and then we amputated about half of the foot. So
Yeah.
that's what we did in the end, and that was the answer. But of course, this is only one case. But we tried it.
Okay.
I don't know what the evidence says about crush injuries in hyperbaric chamber, but.
So, what I like about this photo that you brought here, Julie, is the fact that the pulse oximeter is on the leg that was ischemic. I think that's a very nice point to bring out, that, we do actually do that in our vascular surgery patients as well, as I imagine do others. And, that does make sense also in a patient where you might think that there may be vascular compromise in this sort of injury, or if there's borderline perfusion or a penetrating injury, like for that femoral artery with revascularization or crush to the limb, that's a nice tool to see whether you can still get pulsations and perfusion.
Does any of you use NIRS on these limbs?
Not NIRS, we use Doppler.
Okay.
And ultrasound. Obviously, ultrasound would be the best.
Yeah. Because some vascular surgeons promote the use of NIRS on limbs as well. I have my doubts personally, but of course it doesn't mean that it can't be valuable in some settings, because you do get to see perfusion a bit deeper, especially in the muscle.
I have to say that I lost my faith, but again, you're asking about my opinion. This is not the literature. I lost my faith in NIRS after reading a paper that showed that they put it on 3 patients in post-mortem.
Yeah,
and got a very nice reading. So I don't know, maybe I don't know, maybe there are new ways of doing it.
I suppose maybe the change in the signal can be valuable, of course, and if you put it on muscle, you don't have the trouble of getting the signal through the skull. So you might get a more direct reading of the oxygenation in the muscle itself.
Could be.
Yeah, could be.
Yeah.
There's one question not related to what we're discussing here, but I want to make sure we cover all the questions of our audience. Somebody asks about the maximum dose of sodium bicarbonate in 24 hours for acidosis related to renal failure.
Okay, so I think that brings us to a very interesting point that I'd like to bring across. Not so much the maximal dose, but if you're giving a patient a lot of bicarbonate in 24 hours because they're in renal failure, obviously you need to think what's next. And I think that in a scenario, definitely in a military scenario or pre-hospital scenario or forward hospital scenario, dialysis is limited. And I would say that if you have a patient that's developing acute renal failure, you need to think where you're transferring them as soon as possible, if possible. And if not, then sodium bicarbonate's not going to make a difference.
No.
Probably.
No. So as a temporary measure, yes, but
yes,
definitely you need to think of your transport here as well.
Yeah, I don't think that I mean, again, you're giving sodium, not only bicarbonate. And I think that's the point. So you need to monitor what you're doing, and you need to take into consideration that it will cause fluid overload and you will get stuck with the sodium later on. So, in this scenario, I would say less is more. Aim for a pH of 7.2, 7.1 and a half.
Yeah. Don't be too ambitious.
Yeah.
No.
If you allow me, I also have another case that we have actually in our ICU at this very moment. I don't know how much time we have.
We still have 25 minutes, apparently.
Great. So I want to show another case of crush this time. Let me see where my share screen is. Go back to this. And this case is actually, I think, presents another challenge. This is a case that's lying in our bed number 3 at this very moment. A man that the exact circumstances are unclear, but came in with a completely crushed mandible. Surprising, you know, crush injury can happen to a lot of interesting places. And this is a classic airway scenario, which I would like to highlight for ICU people. I think that it's nice to discuss airway a little bit here too in this context. We do know that loss of airway is airway breathing, if you wish, is the second reason for death in trauma patients. So we've talked about circulation and hemorrhage, but airway is there too, and it's number 2. In the pre-hospital scenario, many times it's because of multiple attempts with performed by people that with less experience. And there has been some literature, there has been some discussion in the literature going on about intubation versus non-intubation, because in CPR, there was literature showing that intubation in pre-hospital probably doesn't make a difference. And then questions were raised about trauma patients, where apparently in pre-hospital scenario, in the right hands, and I'm emphasizing in the right hands, it can make a difference. So again, like we said before, don't become too ambitious. In this case, the paramedic intubated the patient in the pre-hospital, which was actually quite lucky. But because it turns out the patient, and as you will see that a little bit later on, it would have been much more difficult. So this patient had a crushed mandible, and you can see here, the mandible has moved out of its place right here. Let me enlarge this. Oops, sorry about that. There you go. Okay, so the mandible here, as you can see, has moved out of its spot. It's also, it should be, the hinge should be somewhere around here, but it's moved anteriorly, it's dislocated. As you know, this is the strongest muscle in the body. In order to reach a situation where there's such a fracture and dislocation, that is a huge trauma. Now, the patient didn't have a rise in CPK, but there were other interesting points that I'd like to highlight in this case. First of all, this little tiny thing hidden right here that you can see is a tooth, which is not in the place where it's supposed to be. And that is interesting because it wasn't seen initially, because there's such a massive finding here, then you lose sight of the smaller things, but here it is. In another angle, this is how the mandible looks. Usually when you have, there's a big difference between maxillary and mandibular damage in terms of airway management, and I think it's important to emphasize that. When the maxilla is broken and it's not moving, it doesn't move as much. The edema is usually less, and it's easier to intubate. When the mandible is broken, then sometimes the injury is very severe and it can be very difficult to intubate the patient. Here is the mandible that's broken, and here's another tooth. Now, unfortunately, we also saw this. We don't know how many teeth the patient started out with. So we started looking for them. And if you're looking, if you look at the next photos that I'm showing you, these are lateral surviews of the neck. This was the one that we saw before. Here's another tooth in the back, stuck in the soft tissue of the back of the mouth. And here's another one just above the hyoid bone. And that can be very tricky given the fact that the tube may be right next to it, or around it, or above it, or below it, and so on. There was a whole discussion. Here's another angle of seeing these three, where exactly this is. And it ended up that, and I'm going to show you, because originally, the reason I wanted to show this case is, came in the surgeon, said, you know what, this is not an urgent case to do, so why don't you just extubate the patient, let him cool down, and we'll do him in several days, because the ENT doctors and the oromaxillary doctors, they sort of tend to say, let's cool the patient down, get rid of the edema a little bit, and then we'll do the surgery. And that makes sense if there aren't such foreign bodies wandering around the airway, and B, and this is how the airway looked. This is the trachea with the tube in it, and this is the airway higher up. So to extubate this patient would have been probably a death scenario, because the edema was so severe. There was no way we could extubate the patient at that point.
Unless you did a trach, unless you thought about doing a trach.
Yeah, well, correct. But then you could also lose the airway that way too. So we ended up sitting on this patient for several days, then doing a fiber optic switch of the tube, using an extensor going through the, doing a tube switch using fiber optic in order to move the tube from the mouth to the nose, because the original intubation was through the mouth, and then they could actually do the exploration of the airway.
Okay.
But that takes a good deal of experience. That's ideally done with a double setup in the operating room, where you have an ENT doctor in standby for an emergent tracheostomy or emergency coniotomy. So I think this sort of highlights how even a crush injury can end up being something that, not necessarily the way we think of crush in terms of crush, but actually, it can raise other challenges for us as ICU clinicians. They brought in the gastro to do a gastroscopy to make sure that that tooth isn't in the esophagus. Then they did an exploration of the neck, and they found that little piece somewhere in one of the folds just next to the entrance to the trachea. So I think this is also an interesting case of crush.
Mm-hmm.
Yeah, absolutely. It's especially because when it comes to crush trauma, you don't usually think of that area as something that, we usually think of limbs or other parts, but it's good to bring that up as well. We have another question from the chat, again, not related to what we just presented. And I think we're still continuing this pre-hospital versus in-hospital discussion. Somebody asked a question on pre-hospital fasciotomy. What about that? Are there any indications? To me, it sounds like a very risky operation, because you risk uncontrolled bleeding in the pre-hospital setting. But I'm very curious what your opinion would be.
So if you're a surgeon and you know your anatomy perfectly, and you have how to heat the patient and to transfuse the patient, because fasciotomy bleeds. You're exposing a large area of muscle, it bleeds. And I can tell you, we just had a patient bleed up to, I think it was 10 units of blood from an area after fasciotomy in the hip. And it took the surgeons 3 days to find the bleeder. So, it's not, oh, let's just take a knife and cut. I would be very, very hesitant to recommend pre-hospital fasciotomy.
Yeah. I had the same idea. Okay, good. Julie, do you have any more of your nice pictures to present?
Sure. Okay, now, okay, so this is another case where we had crush injury just to the tibia and fibula area, and this is after a skin graft, and this is 3 months later, what it looked like. But you see the swollenness of the leg, and still the toes are quite ischemic. But again, our doctors are saying, okay, there is, as soon as we've stopped the extension of the ischemia, or what's the rush? We don't have to take off the toes. So I just wanted to show this is 3 months later, and still there was no rush to amputate the toes. But you can see the skin grafts were taken here.
Maybe it's an interesting, it's not entirely related, but to discuss infection management and antibiotics a bit in the, let's say, what we have, the 15 minutes that we have left. So obviously trying to get shrapnel out or anything that's dirty out of the patient is important, but Sharon, infection management, how soon should we expect to see signs of infection in these crush wounds? When should we treat with antibiotics? Can you comment on that as well?
I can, but like every other topic on this, the literature is very limited. Obviously, anything that penetrates the skin will need coverage. It's important to know the scenario where it happened. And we had actually, I have to say, some really interesting experience during the bombings where we saw that in scenarios where, this is going to sound a bit odd, but there were fruits and vegetables, we got a completely different flora than what you would see, for example, in a motor vehicle accident. We suddenly started seeing fungi, and I thought, and I think that's important to mention. So you have to know, like, if the patient was lying in the field with an open wound on top of a bunch of tomatoes, then that is something that you would need to take into consideration. Or if you have literally taken bits and pieces of something like wood or fruits or vegetables out of the patient, you need to think what's sitting on those things that you would not normally see in a motor vehicle accident. So that's just one thought. The second thing that we saw, and this was also really important, I think, if there are multiple injured patients and a piece of one patient enters a second patient, then you need to start thinking about cross-infection with things like hepatitis or HIV. Or so if you're seeing bits of bone that aren't of that patient in your patients, then you should check for all those secondary infections that you can get from other people. So that's, a little bit outside the box. Now, talking about the more common, I think, infections, and obviously you'd need to cover staph and strep. And if you have intestine involved, you'd want anaerobes and, all the enteric, all the gut, the standard gut formula. Upper abdomen, in a standard trauma, you might consider antifungal therapy. Again, upper GI, not upper abdomen, upper GI. Again, that's controversial, but yes, more and more places are doing that. So I think that, and I think the more important question here may be actually, when do we stop or downgrade?
Absolutely.
Because, and just standard trauma without spillage is considered relatively clean surgery. So in theory, you could stop within a day.
Yeah, because of course, if the risk of having complex multi-resistant germs arising when you prolong your broad spectrum antibiotics is quite large in these patients, especially with tissue that is so often badly perfused.
Yeah, and I think that, you know, people in the early stages, people used to swab, you know, the areas and see what's on the areas. That's no longer what we do. We stopped doing that. There's no need. And drains that have sat in there for more than 24 hours, don't culture the drains. There's not much sense in that.
No.
Culture the patient, yes, you know, constantly for blood, urine, and airway. And if you have areas that are clearly pus, then that makes sense to maybe check that for, you know, even with microscopy. But I think that you know, in theory, even dirty surgery after day 5, you should start asking yourself, do I even want to continue? Every day should be the question, perhaps I should stop, perhaps I should stop.
Yeah.
That's, I think, the logo. Would you agree with that?
No, I think I would definitely agree with that, and I think it's good to have these specific guidelines as well, because starting antibiotic is easy, but stopping but stopping them is quite challenging. I think it's always more difficult to convince people to stop their antibiotics somehow.
Yes, absolutely. But I think that they, you know, particularly in the ICU scenario, we're so on top of the patients. We're so, you know, we monitor everything, we watch everything. If you see dips suddenly, you know, a patient that was previously stable suddenly has these dips in blood pressure, even if they stabilize immediately, that should raise questions. Or a patient suddenly goes into atrial fibrillation for no reason at all, you should ask if they're septic. It's okay to stop as long as that question is always in the back of your mind if something suspicious happens. And suspicious is not necessarily white cell count and temperature. It can be a lot of other things.
Yeah, absolutely. There's just the inflammation of such extensive crush trauma is bound to give you fever almost. So it doesn't always mean that there's an infection there. Do we have other questions actually on the chat? I believe that the audience is very quiet.
Yeah.
I hope that there's more questions, because that's why we do this.
No more
we
questions.
don't. Okay.
This picture I just brought to show the extensive damage to the femur and the diverting colostomy here. So, you know, another thing that would be regular surgery, diverting colostomy, and see how extensive this crush injury will get, because there's just so much we can do with an injury in this vital area. So
yeah, I think that this picture just brings one point that's very important, is the fact that if you have a good surgeon there, they will be thinking forward.
Yeah.
Diverting colostomy when you have the potential of infection there, a feeding tube when you might not have later access to the gastrointestinal tract, that's looking forward during surgery, and that needs to be done early so that we in the ICU do not have these issues later on to deal with, and the patient obviously gets the optimal treatment.
Okay, Geert, we've had a message here that it's time for us to wrap up this session and give some highlights of what we learned in this session. And I think there was a little discrepancy between what the people were asking and what we were talking about, because we were really talking about managing in the ICU crush injuries and penetrating wounds. So we were talking about how to manage these patients, and the questions were asked a lot about pre-hospital care.
Yeah, pre-hospital care, and in particular hemostasis. So I think that there's definitely a need there, and I think people can look at the previous recorded sessions as well to learn more about that. But I still hope that we were able to give them some important insights, because I think it's apart from the pre-hospital settings where indeed a lot depends on transport times and on local setting. I think the in-hospital management, I must say I did learn a lot about from how we build this up, how we build this session up. In particular, think about other areas such as the facial or neck area, something that we don't usually consider in a crash trauma. I think the acute kidney injury discussion was also very interesting. And when it comes to penetrating, the insight of the robotic surgery is definitely something that I will take home from this session, and that I would have thought to be too advanced, but I see the point that you were trying to make there.
Okay. We'd like to inform the audience about the next webinar on trauma and war management, which will be called Blast and Burn Injuries, and it will be on April 27th, which is next Wednesday, between 5 and 6:30 Central European Time. So we all look forward to seeing you all there, and thank you very much for your participation. Thank you, Sharon, and thank you, Geert.
Thank you.
Yeah, thank you in particular to Sharon as well, who was involved so late and gave such a great. She said she didn't prepare slides, but actually she did. So.
I'm a good scout.
Yeah, indeed. Thank you.
Thank you.
Bye.
Bye-bye.